Yes, sir.
Hello?
Yes, sir.
Yes, sir.
Yeah. Am I audible?
Yes, sir, you
Ask.
are.
Okay, fine. Thank you so much. So, thanks West Zone and your fellowship program, and thanks Abhishek for inviting me for this topic. We are going to focus on the regional strategy for shoulder surgeries, and we move ahead with this particular subtopic, keeping in mind the innovation of shoulder, how it has changed from the previous to the recent one, the recommended RA strategy, the predictor and the RA strategies, innovative blocks, and probable future initiatives. So some of you may not be oriented to the type of blocks that we have been using. We have been doing a lot of cadaveric and clinical studies in that direction. So coming to the innovation of shoulder, like this has been in the past. This is very a classical picture and a text which appears way back in 1946 by E. Gardner. And what the author mentions is several distal nerves which innervate the shoulder joint. And you have to keep it in mind that the strategy might be different from for open surgery and for arthroscopic surgery, for awake surgeries, and for analgesic purposes. Now, if you can see what we do commonly in our practice, or what I think from my side is, I try to see the most distal innervation of the of any joint, and then trace it back. So if you, for example, now this is the suprascapular nerve, which is innervating the superior part, the posterior, and a part of the anterior of the shoulder joint, while this is the lateral pectoral nerve, which innervates most of the glenohumeral and uh, the probably the lateral aspect of the clavicle as well as the joint. So two important are the acromioclavicular and the glenohumeral. Of this, the acromioclavicular is more commonly innervated by the lateral pectoral nerve. Now, if you trace these nerves back, if you trace these nerves back, they appear to emerge from the superior trunk, and this is probably the anterior division of the superior trunk from which the lateral pectoral nerve emerges, while the suprascapular nerve emerges from uh, the main trunk of the superior trunk, which divides into the anterior division and the posterior division. And if you trace them back, it usually is at the level of C5 and C6. So more commonly, if you look at the shoulder joint, is innervated by the C5 and C6, and less commonly from the C7. Now, another very important article by from AIMS Trauma Center in Delhi, and this is from forensic department. You should go through this article. They have performed some cross sections, and they have traced the fibers from the periphery to the center. And what they found was the axillary nerve, it lies more common in C5 and C6. The suprascapular nerve is stationed in C5, which doesn't appear to be in C6. The lateral cord, the lateral pectoral nerve, is more commonly in the C5 and C6. So that's how, more importantly, it lies in the area of C5 and C6. And in the past, it was mentioned that 70% of the times the suprascapular nerve innervated the shoulder joint, which may not be the position of the suprascapular now, because they have done a lot of advanced techniques through which the anatomic techniques through which they have found that it's now that the things have changed a lot, and the other nerves that like the axillary nerve, which was 30%, the lateral pectoral nerve, which did not appear at all in the very past, and the subscapular nerve, the lower one, which was not mentioned at all in the past. Just one or two tweaks. That's all what was being mentioned. But now, if they do a neural mapping of the shoulder joint, they find a lot of things. Like, for the example, the superior branch of the suprascapular nerve, the inferior branch of the same, and the acromial branch. If you see from the superior portion, like from the top, you'll find that this is the acromioclavicular joint, this is the clavicle, and this is the dense area of the innervation of the superior and inferior and the acromial branches of the suprascapular nerve. And the green one is all the lateral pectoral nerve, which appears here, which also appears at this point of time. Here, this is the anterior part of the shoulder joint. This you're looking at the superior part. This you're looking at the
Oh,
posterior part, where you can also see the suprascapular nerve, and again
okay.
the inferior branch of the suprascapular nerve. So
स्क्रीनशॉट
there's a
लेना
lot of.
इसमें हो गया स्क्रीनशॉट.
Can you cut this voice, Abhishek, or ask them to just keep shut down?
Done, sir.
Yeah, or maybe they may not attend this program. That's fine. And the axillary nerve has got a dense thing on the posterior. You can see that it winds around the neck of the humerus, and we find it very much at this point. It's in the anterior part of the again of the shoulder joint. So, couple of things to be taken into consideration: the superior aspect, the suprascapular nerve, and the lateral pectoral nerve. And this is the again the anterior aspect of the acromioclavicular joint, and this is sorry, the posterior aspect, and this you have the suprascapular nerve and the axillary nerve, the posterior division, and this is the anterior division which winds around the neck of the humerus, and this is the anterior part, which is again by the lateral pectoral nerve, very dense by the axillary nerve, and the subscapular nerve, which did not have any say in the past. It looks now quite commonly here at this point. So, all in all, almost like 25% of the times it is innervated by all these nerves. So, the suprascapular nerve, the incidence has fallen down from 70% to almost like 25 to 30%. So that's a big message that the anatomists have given us across the literature, the appearance of the other important nerves, and this makes it very sensible to use more distal blocks in various areas. Anyways, when you do an anesthetic procedure, what we look for is the interscalene block, which can be performed by either neurostimulation or ultrasound, which is a combination of the C5 and C6 and the C7 as well at times. But this is the one which mainly appears to innervate the shoulder joint, injecting 20 ml of local in between the scalenus anterior and the medius. If you inject at this point, start injecting at this point, it percolates, and then uh, it it uh, it anesthetizes the C5 and C6 rami, but C7 and C8 is absolutely not a possibility in this case. Even if you inject around 40 ml of local anesthetic, it will produce more of adverse events, and it's not going to increase the analgesic effect of C8. Now, this is with neurostimulation, where the needle was brought into the interscalene groove, and just you took into the deltoid twitches or the biceps twitches and inject your local anesthetic. And it also used to cause missed segments, because with ultrasound now we see that there could be some scalene muscles which are in between the roots or the rami, and that will appear to lead to inadequate block. As well as the C5 can have variations. It can be in on the top of the middle skeletal muscle, inside the middle skeletal muscle, and away from C6. So all these variations can cause a problem in the immediate block period. Now we understand the phrenic nerve would be at this point somewhere appearing from C5 and then running more medial and superior to the anterior skeletal muscle. Another important nerves are the nerve to the long thoracic nerve and the dorsal scapular nerve. The dorsal scapular nerve arriving from C5, the C6, C7, again the long thoracic nerve in the middle skeletal muscle. And we have seen this a lot in the cadaveric dissections as well. So these are some of the modalities, and I'm not unsure whether we have seen the neurostimulation guided block in the past, where I'll take you step by step here at this point. And here you will see that the needle is inserted at the level of the cricoid cartilage. The needle is inserted at the level of the cricoid cartilage, and if you trace this more lateral, it is in the interscalene groove between the anterscalene and the middle scalene muscle. And look at the needle, it's at right angles to the scalene group of muscles. This is a very important point again. And what you do is you try to insert. You can see that how it bends. You can see that now that it bends as you move. In it, there's sort of click or a pop. And with the neurostimulation at 1 milliamperes, you start getting the twitches of the deltoid and biceps. I keep the needle by itself. The sheath is holding the needle now, and then it means that you are in the right position with the deltoid and the biceps contractions at the level of C5 and C6. It is at this point you inject 20 ml of local anesthetic. So at zero point 0.4 milliamperes and not less than that, you inject your local anesthetic with each aspiration and boluses. The analgesic effect may be within around 10 minutes. This requires subcute infiltration, or it requires the V-shaped infiltration at the level of the axilla uh, for the intercostal brachial nerve. Now, when we come to ultrasound, the needle is inserted from lateral to medial, and it is at the level of the C5 and C6. So this is C5, these are C6, and the needle is just posterior and lateral. You can see that this is the posterior and lateral, and if you insert a needle between these two, it becomes the intraplexus. So this is a periplexus injections. So this is what is commonly performed, and you can see this is the sheath of the brachial plexus. That is the epimysium of the middle skeletal muscle. That is the epineurium of the brachial plexus, and the local anesthetic is situated between these two. And this is one which is called as periplexus. You can see the entire brachial plexus moving away from the site of injections. So this is how these two modalities they work: the neurostimulation and ultrasound. Now, the after effects. Phrenic paralysis, 20 ml, 100% evidence. This is a grade 1 evidence. And this was very classically described by William Urmi in 1994. It appears in one of the anesthesia journals. You can go through it. And he did this block with around 30 to 40 ml, almost 50 ml of local anesthetic. And he mentioned that if it's more than 20 ml, it leads to grade 1 evidence of phrenic paralysis, and it's not a complication, it's a sequel in those days. If you cut down to now with ultrasound, we consider this as an adverse effect if there's a phrenic paralysis, even if it's mild, moderate, or severe. And we always perform a post-op ultrasound diaphragmatic assessment in our institute at 2 hours post-surgery. It may be awake, or it may be anesthetized patient. In the post-operative period, once the patient is spontaneous, we consider that he is come back to spontaneous recovery from neuromuscular relaxation. And it's at this time that we perform the ultrasound assessment of diaphragm at second hour, and then discharge the patient from the PACU to the room. Epidural spread, it has been seen even with 5 ml. Epidural spread, in fact, can be seen from 5 to 20 ml of local anesthetics, and with 20 ml, there is 87% of the times neuraxial spread. Look at that number. So, in fact, I had performed few contrast studies, and I found that when you inject the contrast in the interscalene area, it is always being lateralizing the brachial plexus, and I had presented this at several times in several conferences. So it's true that if you are injecting more than 20 ml, there is a neuraxial spread, and there is also a grade 1 evidence. So grade 1 evidence is all the randomized controlled trials put together along with the even the systematic reviews and meta-analysis. A very important study by Studner, and this is the one which I consider the best to be looked into. Standard volume, they have 20 ml, low volume group 5 ml, and you can see the epidural spread is uh, both with the 20 ml and 5 ml at the rate of 13%, and then spread around the phrenic nerve is more with this 20 ml and less with 5 ml. Again, the intramuscular spread is more. Intramuscular is the one which spreads into the scalene muscle or into the into the scalene muscles. And they consider this important because I will get to you immediately. So the epidural spread is more with intravascular than the extravascular. So I told you that when you inject your local into the into this part between the C5 and C6 intraplexus, that's the intravascular. So in this case, the epidural spread is more. We have seen that. In fact, I just give around 1 to 2 ml of contrast and inject at this point, particularly between C6 and C7. I find that going into the epidural space. So again, a short transaxial neck distance. Again, that's very important. So we have seen that in our studies in our institute, we have seen that if the neck diameter at the level of the cricoid cartilage, neck circumference, if it is more than 40, the incidence of phrenic paralysis is more. So short necks, it does mean that the drug, irrespective of the volume of local anesthetic, it does percolate to the phrenic nerve and it leads to mild to severe paralysis. So that it's volume dependent all the time. There are a few pictures which are from the same author. By the same author, you can see the spread from injected at this point. It goes below the sternocleidomastoid, so the superficial cervical plexus, the cervical rami, the intervertebral foramen, and the epidural spread. Again, the epidural spread. This is a lot of the scalene muscles which have been involved. And again, on the top of the interscalene, so the phrenic nerve, on the top of interscalene, the phrenic nerve. Now, this is the one that leads to myotoxicity. This and the spread at this point, which is we can see in the coronal section here, we can see the spread. So that produces a lot of myotoxicity. In fact, that leads to even neurotoxicity. If it is a continuous catheter system, there's a probable chances of these muscles going into myotoxicity and the phrenic nerve going into a chronic paralysis. So we have to be careful when you inject with the local anesthetics by infusion pumps. And I think we used to do a lot of catheters in the past, as well as we used to do a lot of infusions in the past with around 5 ml per hour, 0.1%. But now we have stopped doing that. We did do a lot of single shot, and for study purpose, we are studying between a, a catheter bolus and a dry stimulation, where we use neurostimulation guided catheter placement in the brachial plexus and just leave like that. And uh, we use that intraoperative 0.2% ropivacaine around 10 ml, but in the postoperative period, we did not inject any local anesthetic through it. And we just stimulate the brachial plexus 1 milliamperes for 5 minutes every 8 hourly. And we are quite happy with the outcomes of the patients in this particular technique. So that's called as the dry catheter without any local anesthetic. And all our junior consultants, they take care of these patients in the post-operative period as well, and the fellows. So let's see what it means that you're injecting the drug in the plexus and outside the plexus. Now, if you see this is a cross section where we can see these are the elements of the brachial plexus. The brown ones are all the fascicles. The yellowish ones is the connective tissue or fat in between the two, and this is the intraplexus between the two fascicles or the two group of fascicles, and this is the C5 and this is the C6. So you can see that it's very nicely engulfed with the epineurium here. And in between the now, if you look at inside of this, there are yellowish structures again, faint yellowish structures. So these are the extravascular. So this is the intraneural area. This entire is the intraneural area. This is the entire neural area with the fascicle and the extravascular, and this is one rami, this is other rami, and this is in between the two rami. So this also becomes, if you insert a needle at this point, uh, it also becomes the intraneural, but it is in between the two rami. So, and if you insert a needle below the epineurium, it becomes subepineurial, but it can be either intravascular or it can be extravascular. And if you insert a needle between the two areas, that is, this is the epimysium of the middle skeletal muscle, that's the area of the epineurium of the brachial plexus. Somewhere at this point, it becomes the periplexus. So you can mention this as the extrafascicular, this can be intravascular, this is periplexus, this is intraplexus. So it's very important to understand the needle positioning. Commonly, it's done as a periplexus and not intraplexus, unless you have been doing a lot of these interscalene blocks for over almost all years. So that's the barrier. Okay, now what's the dilemma with the phrenic nerve? If you look at this particular cadaveric picture that we have, now this is at the level of C5, and this is the emergence of the phrenic nerve from C4 with its another root at the level of C5, and then it courses medially superior to the anteroscalene muscle, and it goes into the thoracic cavity. Now, commonly what you do is you try to palpate the interscalene groove between the anteroscalene muscle and the middle scalene muscle. So you try to palpate at this point, and you, with anatomical landmark, you inject your local anesthetic somewhere, maybe through the omohyoid. It might be above or it might be below, you never know where it is. And then you inject your local with deltoid or the biceps response, 20 ml of local. And if you inject more cephalide, there's 100% chance of the phrenic nerve blockade. So if you look at the course of the phrenic nerve, uh, Kessler, in his classic article on ultrasound topography of phrenic nerve, has mentioned that for every 1 centimeter caudal, there is 3 millimeter separation from the brachial plexus. So as you go more low down, the chance or the incidence of the phrenic nerve paralysis might be decreased. So the puncture point, what has been mentioned with landmark, is always 1 to 2 centimeters caudal to the cricoid, somewhere in the area of the superior trunk with landmark techniques. But of course, now with ultrasound, we are able to understand the difference between the C5 and C6 rami and the superior trunk, and even going still more lower down as it divides into the anterior the suprascapular, the posterior, and the anterior divisions. So this is the reason why we have been moving now more caudal in search of better blocks, which will decrease the incidence of the phrenic paralysis. Of course, phrenic nerve paralysis in ASA grade 1 and 2 are is of least importance, but in chronic obstructive airway disease in obese patients, in pregnant patients, and in ASA grade 3, 4 patients, it seems to be leading to a lot of problems in the perioperative period as well. So superior trunk block, as you scan from the cephalad to caudal, you see the C5, C6, 7, and 8. The superior trunk here is at this point, which is a confluence between C5 and C6, and you need to insert your needle before the emergence of the suprascapular nerve. So you see for the C5, C6, and then you identify the C7 as well, and then you try to see the confluence between the C5 and C6. Just yesterday, we had a very interesting workshop in AIMS, and I demonstrated in the masterclass the superior trunk block in cadaver, and we found that it goes around exactly the same area, which will be the C5 and C6 superior trunk. And if you trace it cephalad, it sometimes spreads to the C5 and in between the C5 and C6. And today we injected again in the afternoon. Today we injected blue dye to just ascertain whether the superior trunk is a separate sheath, the C7 is a separate sheath, and C8 is a separate sheath. So we have injected the blue dye here, we have injected the purple here, and we have injected the green at this point. So tomorrow, Monday, we are going to do the dissections. So what about the comparative study? If you compare between the superior trunk and the interscalene block, phrenic paralysis, it's astonishingly less, 4.8% versus 71.4% with the interscalene. Pain scores seems to be similar. This is for the shoulder arthroscopy under general anesthesia. This is an analgesic block. So compared to interscalene block, this is the one which gives you a non-inferior surgical analgesia, and it led to several openings. Like this was first performed by Burkett, and later on this was a comparative study done by Kim and his colleagues. This is a very important person. A lot of articles by Stavros Mepsodis, and it's very important to understand who the authors are in which particular article. So they did a cadaveric study. So once you do a clinical study, you can do a cadaveric study, or it's vice versa. If you do a cadaveric study, then you can try to extrapolate with the clinical studies. So again, my friend Xavier Sala from Barcelona, he injected methylene blue dye at the level of superior trunk. And if you can see the post dissections, these are some of the images that have been incorporated. So you can just ignore them. But this is the dye which spreads cephalad along the sheath of the brachial plexus C5. It goes between the C5 and C6. It spills onto the divisions, the suprascapular, the posterior and anterior division, and it also spills onto the C7. So this was around just 5 ml of uh, methylene blue dye which was injected. Look at the spread. So probably this can cause phrenic paralysis if the volume is increased from 5 to 10 to 15 ml. Similar on the other side, we can see the spread C5 and C6. So 5 ml, would it produce surgical anesthesia? That's a big question. Now we know that it can be used as a surgical analgesic purpose, but for anesthetic, keeping the patients awake. So Philip Gauthier, way back in 2011, he described 5 ml 0.75% ropivacaine, which was injected into the interscalene area under ultrasound, and they used it for open shoulder surgeries. So we were quite surprised by this particular volume of local anesthetic being used. So I used it for my purpose, but in our case series, it was for a different issue. Now, these were the patients who had severe pulmonary injuries and were posted for proximal humerus. So what I did was I used the interscalene catheter. You can see the catheter here, and this is the contrast. This is how much what volume is the contrast. The volume is just 3 ml. So it engulfs the divisions of C6. This is the C5. The interscalene muscle is devoid of any contrast. This is the middle skeleton muscle where some contrast is seen over here, and this is the spillage from the multiple holes of the epidural catheter that we use. No contrast in the intervertebral foramen, not in the epidural space. The next we injected around 6 ml of contrast. So once you inject 6 ml of the contrast, look at the space, it bulges. It occupies most of the interscalene area, not the muscle, of course. And you can see that it moves from the area of the rami to the area of the just outside the intervertebral foramen. That's the foramen transversarium. So this spills sometimes on the interscalene muscle and can cause mild to moderate phrenic paralysis. So every time we inject 3 ml, we assess for the diaphragm, we assess for the oxygen saturations, and we assess for the breathing patterns. Now with 6 ml, it was mild to moderate, but with 9 ml, you can see the entire spread. It spreads a lot on the interscalene muscle, less on the middle scalene muscle, occupies most of that, so it can lead to complete phrenic paralysis. And the patients become a bit more breathless. They need a CPAP in that case to mitigate the diaphragmatic paralysis. Now you can see this is very close to other areas. It's though the sympathetic chain would be somewhere at this point on the anterolateral aspect of the vertebra, where this is the longus colli. It could be somewhere at this point. While in the recurrent laryngeal nerve will be quite away from this. So these two were not affected, but the phrenic paralysis was evident with from 6 to 9 ml, while 3 ml did produce adequate analgesia, 6 ml of course did, and 9 ml did led to a more robust block. But with 3 ml, 6 ml, and 9 ml, there was no paralysis with 3 ml, 6 mild, and 9 ml, it was moderate paralysis. So this was in patients with severe pulmonary injuries. So it was very much directed to that sort of cohort where you think that would affect their respiratory pattern. So we recommend that 5 ml. It can provide surgical anesthesia provided you use a catheter technique, so that and the catheter is right in that place in that particular area. It's only then that it's possible that you can use the low volume local anesthetic for a surgical procedure. Now we know that the phrenic paralysis with the proximal targets, we now look into the distal targets. The distal targets are the suprascapular nerve, as we have seen, the lateral pectoral nerve, the subscapular plexus, and the axillary nerve. So again, this is the superior. This is the suprascapular, that's the lateral pectoral. This is the posterior axillary and the suprascapular. This is the lateral pectoral, anterior, the axillary. So the targets are these four important nerves. So we are looking into some of the interfacial planes because as the nerves they descend from the interscalene groove, they then move into some facial planes because they need to innervate more distally. They have to travel through these facial planes. So initially, close to the neuraxis, it lies in the paravertebral area. As you move more caudal and lateral, it moves from the paravertebral into the interscalene groove, and from the interscalene groove into the facial planes. So you have one plane below the omohyoid where you find the suprascapular nerve. Then between the pecs, you find the lateral pectoral nerve, and in the subscapular plane, we find the suprascapular. So sorry, the subscapular. This has to be the subscapular nerve and the axillary nerve. So beneath the omohyoid, the suprascapular nerve, it runs parallel. Then you find the axillary nerve, just the subscapularis muscle, and just at its apex, you will find the at the corner you'll find the axillary nerve and the subscapularis nerves more interiorly. And of course, between the pec major and pec minor, you'll find the lateral pectoral nerve. So beneath the omohyoid, this is a very important cadaveric study by Herman, and he injected around 5 ml, and he found that it spreads from the anterior of the suprascapular. So this is the omohyoid, so injected below the omohyoid. So this is all the suprascapular fossa. That's the suprascapular nerve, and you can see that it has been stained above the omohyoid as well, close to the C5, and this is the phrenic nerve which lies on the anterior scalene muscle. So this is the left side of the specimen. So this is again the ultrasound picture. This is the needle close to the suprascapular nerve at this point, below the omohyoid, beneath the omohyoid, and you inject your local anesthetic here. So we have studied this in our setup, the anterosuprascapular nerve versus the interscalene blocks. We did inject 5 ml, and with that, we found that in our setup, the suprascapular nerve was very much less than 10%, even less than that. While the cadaveric study here, it mentions 22%. So a comparative study by these authors, again, it's a very robust study and uh, a good set of authors. So Farja Abdullah, Nasir Hussain, Vincent Chan, Richard Brull, all top-notch research people. A comparative study between the subomoid and the suprascapular versus interscalene for arthroscopic shoulder, injected 15 ml injected 15 ml at the suprascapular nerve, and they found that the clinical outcomes, particularly the analytic outcomes, it was almost similar. So it's a non-inferior. So the suprascapular block is non-inferior to interscalene block. The time to first analysis and morphine consumptions were were always uh, equal between these two groups. But the respiratory pattern, the interscreen block was more affected, and this was a different study which was performed, where they found that the incidence was more with the interscreen block at around 70% and very much less with the suprascapular nerve. So another very important cadaveric study where they had a dose finding study, and they found that a volume of 4.2 ml, if you inject below the omohyoid, it's not going to stain the phrenic nerve. Here you can see the phrenic nerve getting stained, but here you don't see the phrenic nerve getting stained. So this was a high volume of the suprascapular. So if you keep on injecting more than 15 ml, even more distally, so it keeps on staining the phrenic nerve. So if you decrease the volume to around less than 4 ml, the chance of staining the phrenic nerve is less. So that's what happens here. It is more confined to the suprascapular area and less cephalad migration as well as the phrenic nerve stain. So that's how it's very important to decrease the volumes of the injections. Now coming to beneath the subscapularis. So we spoke about the axillary nerve and the subscapularis nerve, which is below the subscap muscles. So this is the subscap muscle, and this is the fascia over it. So just below that, you inject your local anesthetic. We just did the today we did in the afternoon we did the cadaveric injection of the subscapularis area, where we could see the posterior circumflex artery, which arises from the axillary artery, moves into the neck of the humerus. It always has the axillary nerve along with it. In that particular plane, we injected the probably the blue dye. So we're not trying to dissect on Monday and try to see a similar pattern whether the axillary nerve and the subscapularis nerve will be stained with this. So what they use hardly 2 ml of the dye, which affected the subscapularis nerve as well as the axillary nerve in the subscapularis fossa. So you have already injected the suprascapular nerve previously, as what we have discussed. Now you inject in the subscapularis plane, you get hold of these two nerves. Now what remains is the lateral pectoral nerve. So we know that the pectoralis major and minor would be running in this direction from the medial to lateral for the attachments. And if you have already inserted the needle into the subscapularis, you just have to withdraw the needle and direct the needle in between the pec major and pec minor, and you inject around 5 ml in the that particular interpectoral area to block the lateral pectoral nerve. So you get hold of all these nerves now: the suprascapular, the subscap plane, as well as the lateral pectoral nerve. So this is a study by Sunday Koppam, and they do it with different pro placements. We don't do with this pro placements anymore. We do it with the parasagittal. This is the one which we use it for the uh, this is the one which we use it for the subomohyoid anterior suprascapular. But what I'm trying is now, what we're trying now is that you do a single puncture, like the needle it comes from the lateral to medial here at this point, and after you do this block, you shift this ultrasound probe in the parasagittal here at this point. So this probe is brought here in the parasagittal and more lateral, and the needle is inserted retroclavicular. So it goes below the clavicle, and then it goes onto the this particular area. So we are trying to see whether a single puncture can be performed for the anterior suprascapular as well as the subscapular spleen block, which will now have all the nerves except maybe the lateral pectoral nerve, which can be just infiltrated close to the acromioclavicular joint, because that's quite superficial. So again, a comparative study, which is a recent one, and this is by, not recent one, it's by David Oyong. So that's another important person. And the clinical outcomes, they found that the anterior suprascapular nerve block is equivalent to the interscalene block, which is better than the supraclavicular brachial plexus. Phrenic sparing, again, the anterosuprascapular nerve block has got better outcomes considering the diaphragm paralysis with the when compared to suprascapular block and when compared to the interscalene block. So a recent study by these authors from group from Turkey, Yavuz Gurkan. So he is also from this particular group. 5 ml in the interscalene area and the anterosuprascapular, no complete diaphragmatic paralysis in any of the patients. That's very heartening to hear. Partial hemodiaphragmatic paralysis in 21 patients with interscalene block without any post-operative breathing problems, and partial diaphragmatic paralysis only one in this group. And mean pain scores, of course, the at the end of the 24 hours, you will be surprised that the patients with interscalene block have got more pain than the anterosuprascapular nerve block. So probably as you go more distal, the nerve diameter and the volume of local anesthetic ratio, probably that is the one which is causing the pain scores to be more better with the more distal blocks. This is what is my assumption. We have not yet done a study in that direction, but I think we can do some study in that direction as well. Now, this is a study that we have uploaded, and if you look at this, that is the superior trunk. This is the nerve to subclavius. That is the suprascapular nerve. That's the posterior and anterior divisions, and the C7 would be somewhere here at this point. So if you look at this, we have injected at this area because this is very dense. That means this is the point of injection. And in the dye, it migrates cephalad and it also migrates caudal. So more of suprascapular, but you can see 5 ml, it spills onto the anterior and posterior divisions. So the anterior division gives rise to the lateral pectoral nerve, the posterior division gives rise to the axillary nerve. So even the suprascapular nerve, when you inject it, the mechanism of action is possibly it is through the spillage of local anesthetic onto the components of the superior trunk. Also, there is a upward migration until the level of C5. This is the phrenic nerve, which is on the anteroscaletal muscle, which is not stained. But we have seen the staining pattern as well, and we have also reported, and it will be shortly published, where we have seen what's the pathway of the uh, injected dye from the suprascapular until the C5. We can see that it's not affecting the ventral area. It's not at all affecting the ventral area. It's only the dorsal uh, of the interscalene trunk, which is in communication with the suprascapular nerve. And then if you inject very high volumes, it goes right on the top of this of the C5, it curls around and then it comes on the phrenic nerve. So that is the pathway from the suprascapular nerve to the phrenic nerve. And it's called as the phrenico-suprascapular connection, which was described only once way back in 1961 by Kodoma. These are the cross sections at the level of T1. This is the thoracic vertebra. You can see the transverse process here. This is the suprascapular placement of the injections, and this is the subscapular placement. This is again the suprascapular uh, nerves of the brachial plexus, and they're going into the shoulder joint. So this is just the cross sections to understand the diffusion or the migration of the dye in the subscapularis plane and in the subomoid plane. So coming to the infraclavicular, probably the costoclavicular has an important role. We did some study quite long time back, and we did a catheter technique where we inserted the catheter from the costoclavicular and tried to push the catheter through this tunnel into the anterior. You can see this is the catheter, and this is a stimulating catheter. So we inserted a needle in such a way that it is in the costoclavicular area, the bevel facing upwards, and we could see that uh, the catheter being traveling across this until it stimulates the components of the C5 and C6, that's the deltoid and the biceps, and retain the catheter and inject your local anesthetic. So it travels all along the catheter as well into the costoclavicular area. So you have the suprascapular as well as the other nerves that which we have described earlier, which will affect this joint. So this is the costoclavicular block, which has got some role now in the postoperative pain management of the shoulder joint. So this is the costoclavicular area. This is the clavicle. This is the supraclavicular area. And then these are the cervical roots. This is the interscalene area. This coracoid has to be here. So this is the coracoid process. That's the catheter tip. So the changing pattern of post-op management for shoulder surgeries has been interscalene block, which is the gold standard. It's the most recommended, and I still feel that in ASA grade 1 and 2, and sometimes in 3 with very cautious placement of the local anesthetic and ultrasound, we can still pull off with the interscalene block. The superior trunk block is an additional block, almost similar to the interscalene block with lesser volumes. The anterior suprascapular nerve is a well-refined distal nerve block, which can be combined with the infraclavicular block or the costoclavicular block for shoulder surgeries. Also, this block can be combined with the subscapularis spleen block to provide shoulder analgesia. So that's the timeline of these blocks, which have been evolved over time till today. So recommendations: proximal is incremental interscalene with catheter techniques for patients with pulmonary injuries, or you can use single bolus uh, volumes as well. It's not that you need to use catheters all the time. You can give a ultrasound guided single bolus and try to position your needle at the level of C5 and C6, and you do a real dynamic scan when you start injecting a local anesthetic. So to understand that it doesn't spread more cephalad and onto the interscalene muscle. The next block is the superior trunk. And the distalmost blocks, we spoke about isolated plane blocks like the subomohyoid or infraomohyoid suprascapular block, the subscapularis plane block, and the interpectoral block. So these are some of the blocks that have been recommended in clinical practice. Of course, the costoclavicular block have been compared to interscalene, infraclavicular block has been compared to interscalene, but there need to be a lot of still studies to come out to have their role in this particular area. Even these blocks we have been comparing, and we'll soon come out with the analysis of these blocks as well. So this is all what I have from my side. And apart from this, in the past, I used to use cervical epidural catheter techniques for shoulder surgeries. We have done it in the past, but currently we don't do more of cervical epidurals. We do more of the peripheral blocks and not going more central. I used to use stimulating catheters. I could not get the picture here or get the video here. But yes, you can use cervical epidurals, and I have used 5 to 6 ml of local anesthetics for just for the shoulder surgeries with very classical stimulating catheter tip position at the level of the C5 and C6, giving rise to deltoid and biceps contractions. And use this catheter post-operatively for post-operative pain strategies. So I think that's all from my side. Thank you very much for this invitation. If you have any questions, or you can call it a day. Thank you so much.
Thank you, Sandeep sir. This is Ethel.
Oh,
Morning,
you
sir.
are here, Ethel.
Yeah,
Okay.
I will tell this, sir. Sir, it was a nice presentation. Regarding all these blocks, as you said, with your cadaveric study, brachial plexus goes from root to distal nerve from within 5 to 6 centimeters. So wherever you inject, there are chances that drug will spread to phrenic nerve if dose is higher. So any role of reducing concentration of the drug like 0.1% ropivacaine or 0.1%, 0.1 to 5% bupivacaine in patient with COPD and with high risk of respiratory distress?
Yeah, I think there are a couple of ways to reduce phrenic paresis as well. If you look at it into the concentrations, 0.1 versus 0.2% ropivacaine, 0.25% versus 0.5% ropivacaine, then the needle tip position at the level of C5 and C6, C7 and C8, what difference it makes. As well as the catheter techniques, like if you insert a catheter at the level of C5 and C6, C6 and C7, and so these are some of the ways to reduce, and they have compared this, and the phrenic paresis probably is less with 0.1% than with 0.2, less with 0.25 than with 0.5. And again, the volumes of local anesthetic, if you they have already compared now 20 ml versus 10 ml, 20 ml versus 5 ml, 10 ml versus 5 ml, and less than 5 ml. So all this contributes towards the phrenic paralysis. I think there's more importance which has been given to phrenic paralysis unnecessarily in ASA grade 1 and 2 patients, which may not be required in a routine clinical practice. It's only when, as you rightly said, in chronic obstructive airway disease, where you use this, and I have seen and I have suffered a lot when we used to do it with non-ultrasound techniques and inject 20 ml of local anesthetic, and we find that it really knocks off the phrenic nerve to such an extent that I had to intubate this patient, ventilate for a very long time without a surgical procedure, and then send to intensive care unit. uh, we ventilate them and then get them back some other time and then try some other technique. So it all really matters when the phrenic nerve totally collapses, and that's very important to understand. So now with ultrasound, we use very incremental analysis. We do a real dynamic scan. We see the spread, more cephalad close to the interscalene muscle, and if it spreads there, yes, then you need to reduce that. In fact, yesterday during the masterclass cadaver, I think Avinash is here. So he was there as a faculty. So when we injected local in the investing layer of deep cervical fascia, it just flies over the middle scalene and the interscalene muscle. Now, if you inject in the investing layer of deep cervical fascia, where the supraclavicular nerves can be 100% will be positioned there, and if we inject more than maybe 2 ml, it will block the phrenic nerve. So even these things also matters. It's not only the deep blocks, but it's also the superficial blocks which matters. And many times in our colleagues, like for example, two of my colleagues, Avinash and Ganesh, they don't give the superficial cervical plexus. They just do the interscalene blocks for shoulder surgeries, and they argue that there is a probable blockade of the superficial cervical plexus and the supraclavicular nerves. And I don't have a counter argument, because definitely yes, it can sometimes block the supraclavicular nerves even if the interscalene block is provided. The only argument is that the superficial cervical plexus, it arises from C4, it lies in the cervical plexus, while the from C5 onwards is the brachial plexus, which lies in a separate groove, that's the interscalene groove. But as you rightly said, Hetal, yes, the volumes, concentration, needle position, all these things matter when it comes to obese patient, morbid obese patient, and chronic obstructive airway disease. That also, the chronic obstructive airway disease, if it's Gold's criteria 2 and 3, it does matter, but 1, it doesn't matter at all, because the type of fibers they change, the changes occur from grade 2 onwards in the Gold's criteria, in the Gold's classification.
And another question is, what is minimum effective volume for surgical anesthesia for interscalene as well as for upper trunk?
So I think they have it's a cadaveric dose finding study where for the you mean to say the interscalene block or the more distal blocks?
No, interscalene and as well as for upper trunk blocks, sir.
Yeah. So minimum effective volume for 90%, it's around 20 ml. It has not reduced. Even with ultrasound, it's not reduced. It's even still 90%, where you get 90% of the times the all the components of the interscalene are blocked. Now, if you consider that, that becomes grade 1 evidence for phrenic paralysis. So even with ultrasound, with that volumes, it's going to cause phrenic paralysis, irrespective of the needle position and irrespective of the. But another interesting what we find in our studies is that all neck circumference at the level of the cricoid, we always monitor it before we inject local. I mean, if it's 40, we mentioned that he's a patient, irrespective of the volume of local anesthetic injected, who's going to suffer from a hemidiaphragmatic paralysis.
Right, sir. Okay, sir. Thank you, sir.
Thank you. Any questions? Nothing in chats? Please mute the music, everyone. Okay.
Any questions from fellows?
They'll not ask anything. They need to ask. They need to get very much involved in all these things.
Hello.
Yes. Ah, Avinash.
Sir, can I add one thing? Sir,
Yeah, please go
in
ahead.
fracture clavicle, mid shaft or lateral end of clavicle, we prefer upper trunk and supraclavicular. So now I have started giving supraclavicular nerve block at the level of omoid, means superficial to the omoid. Hello.
Yes. Yes. So that is the you're trying to give it more specific the
Systemic.
laterals.
Yeah,
Yes, more
yeah.
specific the lateral or the middle
Lateral branches,
intermediate
middle and
supraclavicular nerve.
lateral.
Yes. Yeah.
Yes,
So
sir. Yes,
as
sir.
the nerve descends, they become more. It becomes more selective blocks. So if we are now able to see all those nerves, you can. When I do the scanning, I demonstrate every
Yes,
time
sir.
how it appears from the
Yes, sir.
investing layer and goes out into the subcutaneous tissues and divide into the
Yes,
lateral,
sir.
intermediate, and sometimes the medial most. So yes,
Yes,
I
sir.
agree with you. It can be more specific and selective supraclavicular nerve block.
Yes, sir. And as you said, sir, if we inject, if we block the supraclavicular superficial cervical plexus just deep to the investing layer of deep cervical fascia, it ascends proximally, but it doesn't happen in the superficial approach of superficial cervical plexus block. It is superficial
Yeah,
to the deep fascia of neck, but it
correct.
may happen in because in 2-3 patients we injected superficial to the investing layer of deep cervical fascia, but it was there was a tunnel and it was going proximal towards the phrenic nerve.
Yes.
Hello.
So this has been described, Avinash. So Pandit in British Journal Anaesthesia way back in somewhere
Hmm.
in 2006, he injected
Yeah.
40 ml
Yeah.
in the superficial cervical plexus area, but this was above
Yes,
the
sir.
omohyoid. And as you rightly said, there are these
Hmm.
tunnels which lead from
Yeah.
or the pores which lead to
Yes, sir.
injection moving from the superficial to deep and can block even the
Yes, sir.
phrenic nerve as well as the
Yes,
brachial
sir.
plexus. Yes.
Yes, sir.
Sir, there is a question from Richa ma'am in the chat. Is there any
Okay.
role of irrigation of fields if phrenic nerve palsy occurs?
Yeah, this has been reported, Richa, that if a phrenic paralysis occurs, you try to decrease the extraneural concentration. Once you decrease the extraneural concentrations with irrigation or washout, it's likely to there will be a diffusion again from the intraneural to extraneural, and again you wash out. So there is a probability of these things happening, but we have not really seen. Only thing what we do is that we don't do all these things. In case if there's a problem, if it's a patient who's posted with COPD or a patient who's posted with pulmonary injuries and he's already on CPAP, we get that CPAP unit inside the OT and we have that CPAP going on with the interscalene block until the end of surgery. So that's the one which keeps the alveoli open up, the functional residual capacity uh, not being decreased after the interscalene block, maybe secondary to the uh, phrenic paralysis. But those are only in those patients with severe pulmonary injuries, with obese patients who are on CPAP, the morbid obese patients who are on CPAP.
Sir, one last question I wanted to ask.
Yeah, Gaurav.
So thank you for the presentation. Every time we listen to you, we feel that we are learning something new. Just wanted to ask
I
whether
have to learn. I have to learn a lot, Gaurav. After our presentation, I also learn a lot from my presentation as well. Tell me, Gaurav.
sir, you are recommending incremental dose in interscalene block. So if like we usually give a single shot block, so what is the volume that you recommend and the concentration that you recommend for a single shot interscalene for a shoulder surgery or a proximal humerus surgery?
That's interesting because I will tell you, it all depends upon the type of the patient as well. Now, it's a elderly patient around the age of 80, frail patient. When we start needling, we see how easily is going into the needle tip is going through all the fascia and the scalene muscles. If it's going very easily without any obstacles, it means that the compliance of the interscalene space is very, very high. So it can accept a good volume of local anesthetic, but it's not necessary to inject the entire 20 ml for an elderly patient of age of around 80 because the fascia are so fragile, and they can easily communicate with other fascias. The moment you inject with some pressures, it's going to burst open into some other communicating space. So in that case, the injection pressures have to be monitored. We go very slow injection of local anesthetic, try to see the spread in dynamic scan from the C5 until the C7. And if we feel that the entire column has been filled with local anesthetic, even with 8 ml of local, we have done very frail patients like around weight of 28 to 32 kgs, around the age of 80. Now, if you cut back to a patient who's very robust and has got a huge deltoid, has got thick fascias, and in that case, if you inject around 20 ml of local anesthetic, it's a very low compliance because the fascia is very tight. Apart from that, it's very interesting to understand the fascia which is ventral to the brachial plexus is more thick and it's more tough, and the fascia which is posterior to the brachial plexus is more thin and it's more compliant. So you direct your needle more posterior and lateral in these cases, and you inject the entire local anesthetic volume and try to again do a real dynamic scan. Now again, we also look into the, I repeat, the neck circumference. If it's more than 40, we expect that the drug spread might be more high. So if you have a neck circumference done pre-op at the level of the glottis, and then anticipate that the spread would be more cephalad, in that case, then you can restrict your spread. Needle tip position again at level of C5 and C6. Sometimes we go even lower than that, but we try to see that in the last case, we try to see that the C5 is also surrounded by local anesthetic. The other way around is to do selective trunk blocks, like what Siva has described in the past. We inject around 3 ml at each level. So 3 ml at the C5, 3 ml at the C6, and 3 ml at C7. In this case, around 10 ml of local would be sufficient enough. But having said that, very operatively, I have always been informed by my surgeons that in very taut deltoids, like patients who have been bodybuilders or they have been aggressive farmers. In this case, in these patients, we have seen that the deltoid is not relaxed at all. The deltoid is not relaxed because they are operating at the level of attachment and not operating at the level of the belly of the deltoid. If it had been mid shaft of the humerus, it would have been a very relaxed deltoid. But they are working at the level of the attachments where it's a tendinous attachment and it is not relaxed. So they need to do a tenotomy at that point. And I have scrubbed with them and I've seen that the deltoids are very tough, very proximal, and in spite of a good block, it is not relaxed at all. They always say that the deltoid is not relaxed. And then they need to have a small incision at the level of the deltoid just to get hold of the fracture site. So this is in my opinion, Gaurav. It differs from patient type as well. And so many factors which are involved, just like for spinal and epidural, so many factors are involved in the interscalene block.
So, sir, just one point. So, if we see in a dynamic scan all the three components getting washed with the drug, then 8 to 10 ml is sufficient for that. But what is the concentration that we need to see?
So the
Whether we
concentration
go,
for the concentration for awake surgery is always 0.5% bupivacaine. I don't compromise with that. 2% lignocaine combined with 0.5% bupivacaine. I use it in a 20 ml syringe and then freshly prepared and start injecting local. This is for a rapid onset and delayed duration.
okay.
But
So you
I think
mix equal volumes,
recommendations,
sir?
the recommendations have been even 0.375%. This is what I had presented it sometimes earlier. You can shift point from 0.5% to 0.375%, but I don't take a chance. I use 0.5%.
Right. Okay, sir. Thank you. Thank you so much.
Any questions?
So Abhishek, thank you for waking me up. I was fast asleep, and
It's okay.
I realized only when you said that you have got a have got a class. So thank you very much for that again, and thanks everybody for attending this. If you have got any questions, you can direct it towards Abhishek. We'll get it sorted out. But I feel that the fellows need to be very much prepared for any of these topics prior to going into this, and they need to be involved in a lot of these discussions without any hesitations. Nobody is going to call you by any ways. So it's very important to have a very interactive discussion.
Sir, there
So,
is one more question.
no, that is nothing now. Gaurav says thank you for the class.
Yes.
So there are no questions. Are there
Okay.
questions? No, you can ask, not an issue.
Yeah, Milind Shah sir has asked. Milind Shah sir is saying that whether do you prefer in plane or out of plane technique?
Yes. That's another important this question. When you do these blocks and the needle is through the in plane, you need to look out for the dorsal scapular and the long thoracic nerves. We also have seen in the cadavers as well, and these have to be avoided at any point of time. We always do that in plane techniques. And the auto plane technique, yes, you can do these auto plane techniques. It's a very short distance, but you need to have a lot of control over the needle. So if you have been doing a lot of in plane techniques and out of plane, for example, the popliteal or the femoral nerves, if you have been doing out of plane, then you can go in for the in plane. Just keep it in mind that the impalement of the supraclavicular nerves, impalement of the nerve to subclavius can occur with the out of plane technique. You need to identify the emergence of dorsal scapular nerve. Yesterday in that cadaver, we could see the dorsal scapular nerve emerging from the C5, and it was right in the path of the out of plane technique. Also, the superficial cervical plexus, the supraclavicular nerves, they would be again in that same path. So all in all, the even the nerves in the out of plane, which has not been mentioned, it's good that you asked this question. So we can start mentioning about these two important nerves in the out of plane technique, which you need to look out for when you do the interscaling blocks.
Sir, one question. Hello.
Yeah, Avinash.
Sir, some shoulder surgeon do shoulder arthroscopy in V chair, while some prefer lateral position. So, does
Yeah.
this position has any effect on the incidence of phrenic palsy? Because in lateral position, the phrenic nerve is in dependent position. That side.
Yes. Yes. So we have not
So,
looked into that,
we are not looking.
Avinash.
Yeah. Yes, sir.
Yes, that's quite interesting to look into because Abhishek, I think he's trying to look into this particular area where they
Hmm.
perform the blocks in the supine position versus the block in the lateral position and how it's going to affect. So I think
Yes,
Abhishek,
sir.
you can take this particular thing, what Avinash mentioned, into consideration. One of the
Yes, sir.
outcomes because they're comparing
Yes,
the
sir. Yes, sir.
yes, comparing the interscale in the supine and in the lateral position. So dependent position, yes, the drug getting diffused, percolating onto the interscalene and into the superior area. Yes, that's an important point, Avinash.
Yes,
Yes,
sir.
sir.
So any questions, Nita? You cannot just move on like that. Nita says thank you, but she has got a lot of questions.
Any
So is it
question?
all right, Abhishek?
Yes, sir. Thank you, sir. Thanks a lot.
Thank you. Thank you so much. Thanks everybody for attending.
Have a nice weekend, sir.
Yeah, thank you. Oh, same to you, all of you.